Good morning, everyone. We'll start with the clinical scenario. Presenting 65-year-old Mrs. M. She presented to our ED with history of a right hip fracture following a fall in the bathroom early one morning. She had comorbidities of diabetes, hypertension, coronary artery disease. She had history of a CABG 10 years ago. However, she was not compliant on her medications. At initial assessment, her vital signs, her pulse rate was 92 beats per minute, her blood pressure was 160 over 90, her random glucose at admission was 360 milligrams per deciliter. She was initially seen by the ED and then handed over to orthopedic surgeons. Had seen and planned for an open reduction and internal fixation for her. So the question at this point is, should this patient be taken up for surgery immediately after the initial assessment, or can she be admitted in the ward for optimizing her comorbidities before her surgery? To answer this question, this is a study we have chosen. It is a study on accelerated surgery versus standard care in hip fractures. It is an international randomized control trial. It was done across 69 centers across many nations, one of which was India as well. It was mainly funded by the Canadian government, the Ministry of Health in Canada, Ontario in Canada. So I'll be critiquing this paper based on the CAS checklist. So going on to the first question, did the study address a clearly focused research question? To answer this, we'll be looking at the PCOT statement. The population, this study included patients more than 45 years of age with a hip fracture that required surgery. The intervention was an accelerated surgery. So the goal of this surgery was within 6 hours of diagnosis. The control was standard care, which was a minimum of 24 hours based on the local standards. The outcome was mortality and two outcomes. One was mortality and the other was a composite of major complications, which included mortality, a non-fatal MI, stroke, venous thromboembolism, sepsis, pneumonia, and life-threatening bleed. The timeline that the patients were followed up for was 90 days after randomization. The inclusion criteria for this study, they included patients more than 45 years of age or older, diagnosed during the regular working hours with a low energy mechanism fracture that required surgery. So this duration, the regular working hours varied across the various study centers. Exclusion criteria, they excluded patients who were on a therapeutic dose of anticoagulation for which there was no reversing drug available, patients with a history of heparin-induced thrombocytopenia, patients who were taking a therapeutic dose of vitamin K antagonist, patients with periprosthetic or open fractures, patients who had bilateral fractures, if they were requiring emergency surgery for another reason such as a subdural hematoma, or if they did not consent or where they were previously recruited in the study. They had done a pilot study initially, and following that, this was the trial that was done. So the inclusion criteria and exclusion criteria was fairly reasonable. Was the assignment of the participants to the intervention randomized? They were randomly assigned 1:1 either to the accelerated surgery, which is within 6 hours, or standard care. It was assigned through a central computerized randomization system, and they had randomly varying block sizes to both the arms. Were all the participants who entered the study accounted for in its conclusion? The loss to follow-up in each arm were included, and they were accounted for. An intention to treat analysis was done, and the study was not stopped earlier. This is the consort diagram. Initially, they had screened about 27,700 patients, of which 16,000 patients had to be excluded because of various reasons. Most common of which was they were outside study hours. After which, there were 7,780 patients who fulfilled the eligibility criteria. Among these, around 4,800 patients were eligible but were not enrolled because of various reasons. And finally, they were left with a total number of 2,970, which they randomized into 1,487 in the intervention arm and 1,483 in the standard care arm. So they had very less loss to follow-up. It was less than 5%, 7 in the intervention arm and 8 in the control arm. However, all the patients who were randomized in each arm were included in the final analysis. Sample size calculation. So they estimated a sample size of about 3,000 patients to provide the study an 88% power to detect a hazard ratio of 0.7 with a two-sided alpha of 0.04 for mortality being the first outcome, and a 99% power to detect a hazard ratio of 0.7 with a two-sided alpha of 0.015 for the second outcome being the major composite of major complications. They also accounted for a 45% overlap between the two primary outcomes. Uh, Assuming a standard care, on the other side, the major complication rate was 30%. Where the participants blinded in the intervention they were given. So the study personnel and investigators were not aware of the block sizes. However, the patients, the healthcare workers, and the investigators were aware of the allocation treatment assignment. So they were not blinded. Only the outcome adjudicators were masked to the treatment allocation. Were the study groups similar at the start of the randomized control trial? The baseline characteristics were predominantly well matched and it was maintained throughout the study. This is a picture of the baseline characteristic. So here we see the mean age in both the groups were around 79 years of age. Majority of the patients were women, around 69% in both arms. They included the various comorbidities which are associated in patients more than 45 years of age and predisposing to fall, such as osteoporosis, dementia, hypertension, diabetes, patients who are already requiring assistance for activities of daily living, all of which were almost equally well matched. The other comorbidities they had assessed for was a stroke, MI. Patients who had all these previously, they were also very well matched. The baseline BMI at presentation was similarly matched. It was 24 in both arms. The systolic BP was 140 in both arms and a diastolic of 78 and 77. Pulse rate was also almost equal. It was 80. These are the baseline medications that the patients were on at randomization. So prior to, this is less than 24 hours of the surgery. So most of them were on antihypertensives like ACE, ARBs, antiplatelets for MI or stroke, statins, beta blockers. 5% of the patients and 13% of the patients in the standard arm were on prophylactic antithrombotic agents and anticoagulations like vitamin K antagonists, warfarin they were on, and NOACs. Most of them were well matched. They also looked at the type of fractures. So 52% of the patients in both arms had intertrochanteric fractures versus femoral neck fractures were in the other 44%. Apart from the experimental intervention, each study group received the same level of care. So there was no major difference in the treatment between the groups. The follow-up was the same. Just a note on the study protocol. So patients in the accelerated arm had a medical clearance by physicians who were available to rapidly assess these patients. They were moved immediately following this into a orthopedic elective or a trauma operating room for the surgery. So if there was any elective cases which were scheduled, they were moved to the subsequent slot, and at the end of the day, there were an extra slot facilitated if needed. So this is in the intervention arm. So patients in the standard of care had medical clearance and they were waitlisted for their surgery according to the local standard practices. So the only difference between the groups was that the physician was available for rapid medical assessment in the accelerated group, whereas in the standard group, the medical assessment was not expedited. So the validity of the study population and outcomes were well defined. Randomization was done adequately, allocation concealment was done, however blinding, only the outcome assessor was blinded. Intention to treat analysis was done and the baseline characteristics were well matched. Going on to the results of the study, the primary outcome was to assess mortality and the other outcome was to see a composite of the major complications. Here we see both in the intervention arm and in the control arm, the difference between the absolute difference between the two arms is just only 1%. So it's 9% mortality in the intervention arm and 10% in the control arm. and the composite of major complications was almost the same. It was 22% in both the arms. So the hazards ratio for the first primary outcome was 0.9 with a confidence interval of 0.7 to 1.1, which is crossing 1, and a p-value of 0.4, which was not statistically significant. Other secondary outcomes that they assessed was specifically vascular deaths. So that was mainly stroke, MI, shock, cardiogenic shock, like that, and non-vascular death, which was mainly infection, trauma, and infection and trauma. So most of the outcomes were not statistically significant, except here in infection without sepsis. In the accelerated surgery arm, it was 11% versus standard care, it was 14%, with a hazard ratio of 0.8 and confidence interval of 0.65 to 0.98, with a statistically significant p-value of 0.032. The other two factors which they found were significant was stroke and delirium, which was less in the intervention arm as compared to the control arm. So here they spoke about infection. So they have classified the type of infection. The most significant infection that they have noted is urinary tract infection, which was seen in 8% in the accelerated surgery group versus 10% in the standard care group, which was with the hazard ratio of 0.78 and a confidence interval of 0.6 to 0.99, which was statistically significant. This they have also considered, saying they have attributed this because patients who were in the accelerated group surgery had a shorter period where they required the urinary catheterization versus patients who waited for a longer time. This is the other results that they have looked at. So the time from fracture till randomization is equal in both the arms. So fracture to the arrival of the at the hospital, from at the hospital to hip X-ray to diagnosis, from diagnosis to consenting for randomization were almost equal. Only the time from diagnosis to surgery. So in the intervention arm, it was about 2 hours, and in the standard care, this was the time taken for medical clearance. This was 2 hours and that was 4 hours, and the surgery was 6 hours and 24 hours. This is the Kaplan-Meier graph where we see across 90 days, which was the duration which they followed up the patients for, both the rate of death and major complications did not show any much of a difference. They have substratified the analysis into two things. One was the time from the fracture till the hospital arrival. So they have classified into less than 4 hours, 4 to 24 hours, and more than 24 hours. However, there was, even on substratifying, there was no statistically significant results which they could obtain. And patients with acute medical conditions. So basically, these are patients who have had the fracture, but before they were randomized, they have developed various complications such as an MI or cardiogenic shock or stroke or subarachnoid hemorrhage. Even among them, there was no significant benefit of doing a earlier accelerated care. These are some of the other tertiary outcomes they looked at. One was the functional motor score. So basically, it is a score between 9 and 31. 9 being completely dependent, and 31 being completely independent. So 13 to 91. 13 was dependent and 91 was independent. Majority of them were 58 and 58 in both arms. And the time required for mobilization also was, they have said it is reduced. So time to first mobilization after randomization was reduced in the intervention arm as compared to the standard of care. However, it was not statistically significant. And they've also measured time to from randomization to standing, from randomization to full weight bearing, both of which was reduced in the intervention arm. They have stratified the patients on randomization to the hospital care into less than discharge. So from randomization to discharge, how many days they were there? Less than 10 days, 10 to 20 days, and more than 20 days. So they have said that around 76% of the patients in the intervention arm were discharged in less than 10 days versus it was only 70% in the control arm, which was statistically significant. This is subgroup analysis. based on the patient's age. So their inclusion criteria was age more than 45 years. So 45 to 65, 65 to 80, and more than 80, of which most of them were not statistically significant. Going on to the next question, were the effects of the intervention reported comprehensively? Was the power calculation undertaken? Yes. Was the outcome measured and were they clearly specified? Yes. How were the results expressed for binary outcomes? Were relative and absolute effects reported? They were reported. Was there differential dropout between the study group and between the study groups that could affect the result? There was no differential dropout. Were potential sources of bias identified? Were p-values reported? Yes. Was the precision of the estimate of the intervention and treatment effect reported? Confidence interval was reported for all the outcomes. Do the benefits of the experimental intervention outweigh the harms and costs? I would say no. So the event rate, if we see in the accelerated arm, the surgery arm, the mortality was 9% versus in the standard care arm, which was 10%, with a hazard ratio of 0.9. The absolute risk reduction was 1%. So the number needed to treat would be reverse of that, which would be 100. But the overall results show that there is no benefit of doing an accelerated surgery. Can the results be applied to your local population in your context? Yes. The study participants were similar to the patients in our care. Most of them had comorbidities. Most of the comorbidities that we see in our patients were covered in this study. Would the experimental intervention provide a greater value to the people in your care than any other existing intervention? I would say no. The initial hypothesis was that the accelerated surgery would be more beneficial as compared to a standard care, which was not proven in this study. So in conclusion, going back to the scenario where our patient, should this patient be taken up for immediate surgery, or can she be admitted for optimizing her comorbidities before the surgery? I would say she can be admitted, optimize her comorbidities, and then plan for a surgery at a later date. Thank you.
Thank you, Christina. A round of applause for Dr. Christina. Any questions?